All right, so let's come together. I know there's lots of neuro-oriented folks in the room today. Let's start over here with David's group. So what do you guys call this movement? You know, what are some questions you want to ask her when you're examining her? And it doesn't have to be you, David. It can be anybody in your group.
One thing I'd be worried about is like embolism.
Mhm.
So kind of like potential lesion, basal ganglia, something like this. It seems to be like one side.
Okay, great. So Dimitri's worried about hemibolismus, you know, worried about maybe some sort of new lesion in the basal ganglia or an area or that area of the brain. Middle group, any other thoughts or things that you'd want to ask about?
I want to ask probably if it's similar symptoms.
Great. Okay, so worried about chorea, asking if there's any family history of other individuals in the family with similar movements, particularly to rule out things like Huntington's. And then last group over here, any thoughts or anything else different to add?
It's about the same, but we want to learn more about like stroke history.
Okay, perfect. So knowing more about her stroke history, I'll give you guys a little bit more information. So this is a new symptom. Her strokes were some time ago. She's never had movements like this before. She says that she's been taking all of her medications, which I'll show you in just 1 second, as prescribed, hasn't had any differences to her meds. She's followed by neurology and also by rheumatology for her prior medical conditions. And she said that she's tried reaching out to both of her providers in those areas to get worked up for these symptoms. She got evaluated by both rheumatology and neurology, and they said we should probably admit her for an expedited workup of this chorea. So I'm going to give you guys her medication list. I'll give you a minute to look over it, and then you can tell me if there are any concerning medications on there or things that catch your eye. Anybody notice any medications that they have questions about or that they think could be relevant to her presentation? Estrogen? And what's got you thinking there? Perfect. Yeah. So she's on a topical estrogen, worried about increased risk of stroke. Who knows what tetrabenzene is? Or who thinks that's maybe something that we should explore? Was that Sam?
Yeah.
So muscle relaxer. Anybody else have any other thoughts?
It's essentially active diet. It's like side effects. With withdrawal or like dose changes.
And what are the side effects that we think about?
Don't know.
Okay. Yeah, perfect, Dimitri. So it's a medication for tardive dyskinesia that affects dopamine levels in the body. So I'm not sure if it's the first line. This was recently trialed by her neurologist because of her new symptoms. Okay, but otherwise she's on hydroxychloroquine for her lupus. She's on apixaban and aspirin as well for antiphospholipid antibody syndrome. And then she'd been given some methylprednisolone to take. She says that she has a very bad reaction to steroids, so she actually had not started taking it at home. And then just her tramadol for pain medication. Okay, so let's come back to this. She's admitted for expedited workup. The ER gets some very basic labs on her. You can see with her CBC, she's got some abnormalities there, BMP and then LFTs. And then again, just a reminder for the LFTs, it's total protein in the top left, then albumin, total bilirubin, then direct AST, ALT, alk phos. So I'll give you guys a couple seconds to look over her labs. And then if someone could walk me through what her labs are and what's abnormal and what you're thinking about, we will take a next step and chat through our initial differential for her.
Oh, yeah. It's small.
All right, do we have maybe a med student or an acting intern who could walk us through this patient's labs?
We said that she's got sort of a leukopenia.
Perfect.
Anemia.
Mhm. Yeah, and then when you're evaluating somebody with her medical condition, so as a reminder, she has a mixed connective tissue disorder, she has lupus, antiphospholipid antibody syndrome. What do you think of that abnormal CPC? Does it raise any questions? Is it normal for her? Roxanne, I see you nodding your head yes. Yeah. So could be normal for her with her history of lupus. Leukopenia is a finding that you can see in individuals who have lupus and doesn't really mean that they're, in an exacerbation or anything like that. And then same thing for her thrombocytopenia with her antiphospholipid antibody syndrome. Some people have thrombocytopenia associated with that. Her anemia, could be of anemia of chronic disease. We'd have to go back and trend those to see, but otherwise her labs are fairly normal. And a protein gap. Excellent. All right, so what I want you guys to do is come up with a differential for these abnormal movements that she's having. We talked about how she would meet criteria for chorea. And so what's her differential for somebody coming in with new onset chorea? Go ahead and talk for about a minute or two with your groups, and we'll walk through each group individually. We'll start here on the left-hand side of the room with Sam's group, and then we'll work our way across the room.
Yeah, I got you.
Yeah. Yeah.
Oh,
All right, so let's come back together as a big group. Dr. Albert points out in the chat for the patient's labs. He points out, what about her INR for someone with antiphospholipid antibody syndrome? So her INR was 1, if you recall. People with antiphospholipid antibody syndrome typically get treated with warfarin. She's on apixaban. We will talk more about her anticoagulation, but an INR of 1 doesn't necessarily tell us much about her being therapeutic for her anticoagulation, since it is not a vitamin K agonist. But let's get chatting. So group 1, you guys over here on the left side of the room. So what's on your differential for somebody coming in with a new onset chorea?
Maybe we talked about it was unilateral, so we think of maybe like stroke or some sort of focal neurologic
Okay.
process.
Perfect. All right, table or group 2, other thoughts?
We talked about if you get a history to that Huntington's on the list or prion disease. And I think maybe some manifestation on autoimmune stuff for lupus and
Okay, so Huntington's, ID, some sort of prion disorder or prion disease, and then autoimmune. Is this something to do with her lupus or her antiphospholipid antibody syndrome? Great. Last group. Okay, seizures. All right. So excellent differential that you guys have come up with. I had a very similar list when I was going through this case. And so you guys are entirely accurate. Individuals who have a stroke, if they have a stroke in a particular spot in their brain, they can end up with chorea. Does anybody happen to know which spot that is or which areas? Caudate, subthalamic nucleus is another place, basal ganglia, anything in that area. And then Dr. Albert's also pointing out her antiphospholipid antibody syndrome can also cause hemibolismus, or medications can cause it as well. So never forgetting all of those. Other things that I came up with on my list. Yeah, so Elizabeth is shouting out perineoplastic, which is correct. So don't forget about other things. Synonyms chorea, so usually in kids, rheumatic fever with group A strep. You can have issues with neuropsychiatric lupus. You can have perineoplastic syndromes, especially with ovarian cancer. Anti-NDMA antibodies can cause people to come in with new onset chorea. And so it's a pretty extensive list of things that can cause this pretty narrow diagnosis of chorea. And so for this particular patient, what do you guys think we should be most worried about? What's highest on our differential for her? And anybody can shout it out. Stroke, great. She has a prior history of stroke. We're worried about stroke. Anybody worried about anything else? Medicine toxicity, is that what I heard?
Yeah.
Okay, from her tetrabenzene or, okay. And then perineoplastic, perfect. Yeah, protein gap pancytopenia, making sure that we're working through that. Excellent. Any questions on this part so far? Okay. So now with your groups, based on the differential that we have, I will tell you that she's got no family history of any sort of genetic disorder like Huntington. She's 50 years old. So it'd be kind of a late presentation if she suddenly were to have it. So talk through which labs you want. We'll do studies next. So just think about labs. What are you going to order to work up her chorea? And why? Why do you want them? So take about 2 minutes and talk through which ones you want, and then I'll give you those values if we ended up having them on her.
That is fascinating.
do.
really good with it, just wants to use them. Right. Also, and when we. Are you going to? You do it here. And she has struggles with her brain. You know, a little bit scary.
We do like a TSA.
All right, so I'm hearing a lot of good labs being tossed out. Let's start with our middle group here. And let's talk through what labs you guys want to get and why. The why to me is the most important thing, so we can talk through your clinical reasoning. So what labs are you guys going to order on her?
Foxy told me to say 14. No, yeah. Yeah. But make for that, also, some coagulations, PT.
Sorry, what was the first test that you ordered? I couldn't hear you.
CSF, like specifically for like a destination for CJC.
Okay, so okay, looking out for CJD and the CSF, great. Group 1 over here, what labs do you guys want to order? Okay, differential. Anything else?
Not in the lab front, sorry.
Okay,
I'd like to just.
you guys up here, any other tests that you want to order?
I mean, we're talking about an LP, CSF. I don't think we were thinking like, I think we thought on our differential, there's also the autoimmune.
Perfect. And so what labs are going to order on her CSF to figure out if it's an autoimmune issue or not?
Like glucose protein.
Great.
So,
Okay, and maybe some antibodies. We'll ask our specialist maybe. Okay, group 3 over here. What else are you guys going to order in terms of labs? Okay, complements. And why do you want those, Sam?
Lupus flare.
Okay, so is this patient in a lupus flare? Anything else that you guys want? CRP? Same reasoning?
Yeah.
Okay. Last call. Any more labs? All right. Who here feels comfortable ordering labs to see if a patient is in a lupus flare or not? Raise your hand if you feel uncomfortable. Great, that's all of us. Yeah, so let's talk through how we evaluate whether or not lupus is playing a role in her particular presentation. So C3, complement C3, C4 are good places to start. Let's put up what some other labs that were checked for her lupus. So you can certainly check inflammatory markers. So her CRP and ESR were not all that elevated. ESR is a little bit high, but within her previous range. You can also check complement, C3, C4. I'll tell you that these values are low. Do you guys know if they're low or high in a complement flare or in a lupus flare? Low, perfect. And then the last one that you can also always check is an anti-double strand DNA antibody. And so altogether, these are the labs that you should check whenever a patient with lupus comes in to get a marker of whether or not their disease is active. So again, just to review, CRP and ESR should be high, C3 and C4 should be low, and then her anti-double strand DNA antibody would be high. Why do you think we check a UA in patients with lupus who might be flaring? Perfect. Lupus nephritis. What do we expect to see on her UA if she's having a lupus nephritis flare? Yeah, protein, RBCs. So this is the air quote active sediment that the nephrologists talk about. So they'll have WBCs, RBCs, protein. And so you just got to watch out for all of those. So you can see that she does have some red blood cells and some white blood cells, but her protein level was actually normal on her UA. Then you always want to compare to prior documentation, like in her rheumatology notes, to say like, what does she normally look like when she's in a flare? And so each patient is a little bit individual that way. All right, so we have some lupus labs that we've gotten. We can cross those off. We wanted a differential on her CBC. Didn't have one from when she was admitted, so unfortunately we'll have to cross that off. And then she didn't have any other coags checked aside from that INR. CSF we will get to. I'm going to give you a couple other labs that the team who took care of her checked. And so she had an HIV that was normal, an SPEP that was normal, and then an IgG level that was checked. She also just came back today or recently over the weekend, but she had hepatitis antibodies that were sent, and those were all negative as well. Okay. I will give you your CSF in just a little bit, but let's talk through our next question. So a couple of you guys were like, forget the labs. We don't want to talk through those. We just want to get some other studies. And so talk through what other studies you want and why you want them. And then be as specific as you can. We'll go through them together. I'm going to give you guys only about 45 seconds to go through this one since I anticipate it's a shorter list. And then we will put her all together.
You need a seat. You wanted to know if she had a short brain.
All right, so hearing some good talk. Let's start with this group here. What test do you guys want?
Spot EEG.
Okay, spot EEG. And then why do you want that, Sam?
Rule out seizures.
Okay. Anything else? MRI? With and without? And then of what? I know it seems obvious, but I want you to be as specific as possible.
Oh, great.
Okay, perfect. And then what are you looking for on this?
All types of things. Stroke, like tumors,
etc.
etc.
Okay, perfect. Middle group, anything else that you guys want? Same way? Okay. And then first group, anything else that you guys want? People shaking heads no. Okay. All right. So we're going to start off. I'm going to give you the read of her MRI. I did not pull out any images because I am certainly not a neuroradiologist. So let's zoom in. Okay. So I'm going to give you guys a couple minutes to read through this, but I'll highlight out the pertinent points. So just got some findings. Okay, questions on that? Let's get down to the impression. So recent infarcts involving the right postcentral gyrus, the left caudate, bilateral internal capsules, and left cerebellum. There's no hemorrhage. Extensive calcifications involving the bilateral globus pallidus and dentate nuclei. Not significantly changed, suggests Fair's disease. And then chronic infarctions of the bilateral corona radiata and new chronic appearing infarcts in the left frontal lobe. Okay, have we solved the case? People are saying no. Why not? Why not, David? Why are you saying no?
We don't know why she's having strokes.
Exactly. So this is an interesting point for this particular patient. So she was actually seen in a rheumatology clinic, and rheumatology clinic said she needs to be directly admitted. And neuro said, well, we think that this is probably just some sort of stroke that she's having, but we have to figure out why she's having strokes. So especially with her history of antiphospholipid antibody syndrome, that could be why she's stroking. And if that's the case, then we maybe have to change her therapy for that. And so what's going to be the definitive test for us to figure out if her strokes are due to her lupus? It's the one thing I haven't given you yet. Yeah, so we got to do her LP, and then we have to figure out on her studies if it's consistent with her lupus. So let me give you those labs now. Okay. So I didn't save them, but I will write it out for you. So for her CSF, it was clear and colorless. She had about 140 red blood cells. And then for her white blood cells, she only had 2. And her PMN percentage was low. I want to say her lymphs were about 30. And then she had some monos, that was about 10, and then other, which was about 14, if I recall off the top of my head. Her glucose and protein. Glucose was about 50s, and her protein, what would you expect it to be if it was maybe due to her lupus? High, right? So you have all these antibodies, things are being made. Her protein was fairly normal, around 60, so not super high, not high enough to be diagnostic of neuropsychiatric lupus. Okay. There are a couple other things that we could possibly send off for her CSF. Any thoughts about diagnosing neuropsychiatric lupus? I think a couple of you took care of her when she was here recently, or was she your patient?
Yeah, she was.
Any other labs that you sent off on her CSF to evaluate her?
Yeah.
Do you want to tell us what they are?
I honestly, I can't remember.
No worries at all. Okay, no worries. Justin, are you on the same team?
I was a while back.
Okay.
Anti-neuronal something.
Close. So there is a ribosomal P protein that could be sent off. And then she also had oligo clonal bands sent off. This is still pending, and her ribosomal P protein was negative. So that is a protein that can be associated with neuropsychiatric lupus, but the data is actually not all that strong. So it could be suggestive, but it's still not definitive. Okay, so after this LP and with her MRI, they concluded that her chorea was likely due to these new strokes that she had, but they didn't think that it was due to like a lupus flare or neuropsychiatric lupus in particular. But it still raises the question of her anticoagulation and saying like she has antiphospholipid antibody syndrome. So could this just be due like a new clotting event in her APLS, which is possible. And so hematology was consulted to talk about her anticoagulation. And I'm not sure, have you guys ever tested for antiphospholipid antibody syndrome on a patient coming in with new clots? No? Okay. So there's a couple things that we always check. And then Michelle is asking, why didn't they think it was just progression of her Fayer's disease? So Fayer's disease is this condition where you can have calcium deposition in the brain. Her scan looked stable compared to her prior CT, so they didn't think that it was due to the calcium deposition. And rather these new strokes were perhaps suggestive of a new lesion in her brain. So antiphospholipid antibody syndrome. Anybody have a way that they think about it?
Without providing a lot of detail, I just feel like you're just in a hyperthyroid stage transient in your life, so things happen that aren't good, like the little baby strokes and miscarriages and things like that. Because you have the antibodies, the antiphospholipid. which-
Perfect.
Yeah.
Yeah, so Maria is hitting the nail on the head. Individuals who have antiphospholipid antibody syndrome have a higher predisposition to both arterial and venous clotting. And it's usually due to an underlying disorder. So it can be an autoimmune disorder, or it can be like a perineoplastic type syndrome. And some people, they have it and you have no known cancer, but they can present with one later on down the road. And so for phospholipid antibody syndrome, there are a couple of labs that we check. And I only bring this up because when you guys rotate through the ICU and things like that, people will come in with PE, and there's always that question of like, what are the labs I have to send to make sure this person doesn't have antiphospholipid antibody syndrome? And so, Irvin, if you want to name off any, feel free. We can talk through together about them. If anybody knows any of them, they can shout them out. Perfect. So Roxana is saying anti-cardiolipin antibody. The syphilis one is not one, but yep. So there is a lupus anticoagulant, or sometimes this is like the Russell Rapid Viper venom test. If you hear that name instead, that's part of the test. Not microsomal, but there is similar. What was that? Not mitochondrial, but I know what you guys are thinking. Let me give this your beta 2 microglobulin antibody. And then for both of these, you can have your IgG or your IgM. And the way that we test is that you test the patient when they come in, and then you have to recheck them 12 weeks later and see if their antibodies persist. If somebody has already been on anticoagulation, so like this patient in particular, the lupus anticoagulant is not reliable to interpret. So you need to make sure you send off those other two. So if you have somebody coming in with arterial clots or admitted through the ED and you want to test them for antiphospholipid antibody syndrome, it's always useful to call down to the lab and say, do you still have some blood left from the very first tube that was drawn from them before they had any sort of anticoagulation in their system? And so that is a way for you guys to get around that if they were started on anticoagulation. And so for her, we can walk through her labs. The lupus anticoagulant was not sent as far as I could see. Her anticardiolipin antibodies were negative, and then her, sorry, it's the beta 2 glycoprotein. They were both negative as well. So her tests all came back negative. She'd previously had some positive tests in the past. The decisions that had to be made about her, so if you remember, she was on apixaban. The one thing that I will let you guys know is that most of the data we have on individuals with antiphospholipid antibody syndrome show that warfarin is actually a better medication for them to be on, especially if people are what we call triple positive. So if they have all three of those antibodies, then they should be on warfarin. We just have data that shows that people who were on rivaroxaban compared to warfarin tended to still have clotting events through their anticoagulation. And there was some data to compare and say, if somebody has antiphospholipid antibody syndrome, should I put them on aspirin and anticoagulation? And the data with that was not as clear in terms of a benefit. So if you're thinking, oh, this person has antiphospholipid antibody syndrome, what should I start them on? Chances are you're going to be putting them on heparin, bridging them to warfarin once you talk to your hematologist and rheumatologist about this. And so she actually got switched from apixaban to warfarin with these new strokes because they were concerned it could possibly be her antiphospholipid antibody syndrome not being as well controlled. Irvin?
I don't know if you said this, but stepped out, but she was on warfarin to start,
Mhm.
but then she couldn't keep it in the therapeutic range. So then they did it like off-label apixaban because they knew it wasn't like first time, and that's when she had her.
Yeah. So Urban giving us a little bit more history. So she was on warfarin first, couldn't get her INR therapeutic or high enough. And so switched her to the DOAC for ease of patient dosing, and then ended up switching her back. If people are still stroking through their like INR goal of 2 to 3, you can always bump them up from like 3 to 4. Obviously, if you're getting to that territory, you're probably talking to the hematologist and rheumatologist to guide your thinking about that. But before we end, just a couple quick points on lupus and all the things that it can affect. Today we talked specifically about, the brain. So neuropsychiatric lupus. People can have chorea. So just think about that. If you have somebody coming in with lupus and a new movement disorder, it could be their lupus causing that. It's very rare. I think it was like less than 1% of patients who have neuropsychiatric lupus end up having chorea. What are some guys that you think about when it comes to the bone? We've just talked about this. Yeah, so people can have cytopenias. It's generally leukopenia. And then, we can kind of put this like antiphospholipid syndrome in there as well. Great. The heart. Nobody mentioned this, but it could be. Yeah, perfect. So Roxana is saying endocarditis. Do you remember the name that we give it? Yep. So Liebman-Sachs endocarditis, non-infectious. That could have caused her strokes if she had, thickened valves and she was like tossing off something. They didn't think that was likely in her particular case. But endocarditis, general issues with CAD. So somebody comes in, they have an MI at a very young age. You might think about something rheumatologic going on. We also have lung pathologies. Anything that you guys know of or off the top of your head you can think of? ILD, pleuritis, people can end up with effusions. There's this thing called shrinking lung syndrome that can also happen. Yep, pulmonary hypertension can be an issue. Liver. What if I said her AST, ALT are in the thousands? Yeah, so an autoimmune hepatitis can happen. Same thing with pancreatitis and autoimmune pancreatitis. We already talked about lupus nephritis with the kidneys. And then Maria mentioned recurrent fetal demise. If people have miscarriages, it could all be from their lupus as well. And then we have all the cutaneous manifestations of lupus. So things like discoid lupus, the malar rashes, and whatnot. Questions on this? Okay, so I just feel like we don't often see neuro things and we don't really think about movement disorders that much. So today we talked about this patient who came in with new onset chorea. We talked about how it could be due to her prior history of strokes, her history of lupus, her history of antiphospholipid antibody syndrome. We talked through interpreting labs that could be normal for a lupus patient. So with leukopenia, our differentials and tests to walk through for an individual coming in, knowing that if her CSF were to be positive for this ribosomal protein, and if she had elevated protein in general in her CSF with lots of white cells, that could be representative of a lupus manifestation in the brain. Looking at her MRI to see that she did have indeed new strokes, but knowing that's not the end of the story, like David pointed out, we have to investigate why she's stroking. And then just a quick review of all the different things that lupus can affect. Questions on any of that? Sam?
Would you echo her?
So I think that, I would recommend getting an echo on her. Neuro recommended that just to make sure, even for the general stroke workup, that nothing else was seen. I didn't see necessarily if it was done or not. Urban, you can probably help me out if you guys got that echo.
We did get it.
Yeah, I think it was deferred just because they didn't think it was high on their differential in terms of why. But great question. Okay, and then I'll point out one thing that Michelle is sharing in the chat. CRP greater than 50 can cause a false positive antiphospholipid antibody syndrome testing. She said heme ask for CRP levels if the testing is done in someone where the diagnosis isn't a slam dunk, and they'll hold on the formal diagnosis until CRP is normal with positive testing. Okay, tomorrow we will have a Department of Medicine M&M that will stream through Zoom. Wednesday, we're doing a clinical reasoning conference. And so some of the students that were here last month, you guys participated in this. what I'm gonna do is give you information 5 times throughout the course of conference, and you guys are gonna work on your differential and talking through why you think something is possible or not possible. And then we'll get the final diagnosis at the end. We'll talk through some basic facts about it. Thursday, our Plum Fellow is giving a talk on ARDS, and then Friday will be another case conference as well. So please come see me if you have any questions. I will start observing teams on rounds this week, just to see how things are going and hear about cases. And then just let me know if you guys have any questions. I'm here for you.
Then,